Here we go. Okay, yeah. So maybe we could just go to the next slide. Yeah, this is topics, of course, relevant now because of COVID and all the telemedicine. But it's interesting. We actually have a long history of using telemedicine for dementia care, and this is dating back over 20 years or so. Most of this started for rural health, and as the map shows, this is from 2000 census, but I mean, most of the West, most of the rural areas are kind of on the west side of the country. So over these 20 years, I mean, we've gained quite a bit of information on how you really assess cognition and dementia using telemedicine techniques. Next slide. But things have kind of changed because initially, at least before COVID, and actually before getting reimbursed to do things through Zoom and such, the model for telemedicine was kind of this hub and spoke system where the provider would be at a institution, and patients would actually come into rural sites. So it could be either a hospital or a community center or a community college that had the telemedicine equipment, and there'd usually be a facilitator. So you'd have somebody there, and the advantage of that is that you had kind of reliable connection. You had somebody there to kind of run the visit, and so that worked. I mean, that was kind of a good way to do it. Now, of course, we have direct to consumer, direct to patient delivery, and that, of course, has a lot of advantages. That is, you can reach almost anybody wherever they are that's connected. But the disadvantages is just this variable access. Some people don't have devices that are available to do telehealth. If the bandwidth differs depending on where you are and how many people in your house are using the bandwidth at the same time, and so on and so forth. So those are certain barriers. And of course, for older folks, just signing in, so it could be a challenge. So I think as we're getting better with Zoom, as everybody's getting better using Zoom, it's going to be certainly a valuable way to assess cognition in individuals. However, just keep in mind, I think in terms of kind of a public health system, there are some gaps and barriers that we need to overcome. Next slide. So I guess a lot of this you all know already, but I'm just going to review it anyway. So I think one approach, particularly if you're in the front line, is who should you be testing? I mean, who really are those that it warrants taking the time to do some type of cognitive testing? And I just put three kind of buckets. So of course, people who have a cognitive complaint, either from the patient or the informant, those that you kind of have a clinical suspicion because of other things. They're missing appointments, they're not renewing their medications on time, and such like that. And then also, I think people who have a higher risk, and certainly the older you are, the higher the risk is you're going to have some cognitive impairment. So screening people who are 65 is probably not, who don't have a complaint, is a very low yield task. But if you're 85, then your yield is going to get much higher. And then these other risk factors, cardiovascular risk factors. If you know of somebody's family history and they have a genetic predisposition. So I mean, there's certain people that you may want to screen even though they're not coming in complaining of cognitive impairment. Next slide. So in thinking about screening people, I guess, at least my thought is that it's good to know what you're going to look for as you go into that screening process. And just to review, the most common causes of, certainly the most common causes of dementia are Alzheimer's disease, followed by Lewy body disease as far as neurodegenerative conditions, and then vascular dementia or vascular burden. So those take up the wide majority of people who will have dementia. But then there's those that have cognitive impairment. Maybe they're not totally demented. And those, you have a kind of a wider purvey of things that might cause it. So of course, drugs are the first thing, we think about, depression, other comorbidities. So I think in thinking about that approach and screening, these are the things you're really looking for. I think that can be helpful in determining what you're going to do as far as your examination, and in trying to pull out things in the history. Next slide. So, of course, the history is the most important thing. If you have 15 minutes to spend on somebody, I would spend 13 minutes on, or I don't know, 12 minutes on the history and 3 minutes on the exam. And I think that's a key part, which is the cognitive testing, which I'll talk about, really is, to me, is always kind of just a confirmatory thing. It's just really to confirm what you've drawn out from the history. Now, again, as you know, it's really helpful to have an informant present. If the informant isn't present, of course, there may be times that you would have to talk to the informant separately, either if they're not present in that visit, or if you get the sense that that informant's not being forthright. That is, they're concerned because the patient's going to get mad at them or something if they say too much. But again, I can't stress, so much that really the history is so much the key in cognitive work. Next slide. So what are the key elements that you want to pull out from the history? And I don't want to, kind of belabor this too much. Again, I know that you guys know this, but certainly the presenting symptoms are the key part. In most of these conditions, memory loss, so short-term memory loss is going to be the main complaint. And certainly that's the characteristic of Alzheimer's disease. It's certainly present with Lewy body disease. And vascular dementia may be kind of sketchy, or patchy, but trying to get out this history of difficulty with short-term memory. And frankly, if you don't get that history, it does change your differential quite a bit. Other things are, word finding, searching for words, behavioral changes, and not so much necessarily kind of agitation or irritability, which can be part of it, but apathy, loss of interest, decreased initiative, or again, very common behavioral changes even before the cognitive parts become apparent. Depression in somebody who's never had depression in their life can be a red flag that there may be actually a cognitive problem going on. So in trying to get that history, those would be some of the key elements to try to tease out. And then again, these other parts, what's the onset? Is it a gradual progressive problem, as you would see with a neurodegenerative condition? Is it stepwise, as you might see with vascular disease? Is it more of an abrupt onset, which would then kind of change the differential to either more acute structural things or other comorbidities and such. So onset, progression, again, the gradual versus stepwise, and then any risk factors that may be useful, family history of dementia, for example, or again, this issue of comorbidities such as cardiovascular disease, which often, of course, goes with cerebral vascular disease. Next slide. So once you've gotten that far, I think then the question is the cognitive screening, and what should you do? And so there's things you can do kind of just informally. on your, you could have your own battery, but there's also some standard batteries as well, which we'll talk about. I think whatever battery you do, it's very useful to have certain elements included in it. So that is elements that do kind of sample short-term memory, elements that test what we would call executive functioning, that is higher levels of processing Again, both of those are very common in almost all forms of dementia, as it turns out. And I think some test of attention is useful. If somebody's inattentive, of course, it's hard to judge the rest of their testing, but even the fact they're inattentive may be helpful and suggest other potential disorders in the differential diagnosis. So like drugs, for example, or metabolic things that just kind of affect attention and thus these other elements in the cognitive exam. So, so you can do your own thing, or you could use kind of standardized tests that have been adapted to telehealth. And I'll just kind of show three of them. You could probably modify anything for telemedicine, but there's what we call the blind Mocha. There's a shortened Mocha test. And then there's, if the person cannot use, for example, Zoom technology, and it's just a phone call, there is a telephone interview for cognitive status as well. Next slide. So the blind Mocha is pretty much what it says. I mean, it basically just eliminates all the visual parts of the Mocha. So you don't have the Trails B test, you don't have the copying a cube, you don't have the clock drawing. But that's really actually okay, because the rest of the Mocha does have elements, again, these elements that you probably want. So they have elements of the delayed memory, they have elements of attention, they have elements of executive function embedded in it. And so basically, you know, it's just something you could read and go through with the patient. Now, if you eliminate those the visual part of the Mocha, now you're down to 22 total possible as a score. And so it's just been suggested from research of the blind Mocha that scores, so the score should be 18 or over, or let's put it a different way. If it's below 18, it's probably abnormal. And so this can be a very useful just way to use a standardized test, just eliminating the visual component. Next slide. Then there's the kind of quote unquote 5-minute Mocha. So this is kind of more akin to what used to be, well, what's the mini cog, which is, you know, just a recall of several words, drawing a clock, and then back to the words again. So, although this may be a little better, and actually it is better, because the memory test is a little harder. Now you have 5 words. And as far as the kind of executive function test, they use verbal fluency. And that's just naming all the words you can think of that start with a certain letter in a minute. So you have the memory, you present the memory words, do the verbal fluency, then do orientation, which is again kind of a memory test, and then back to the recall. On this test, so now we're to 15 points total, and below 11 would be considered abnormal. So if you even want to just do a quicker screening test, this kind of 5-minute Mocha is something that's easily adaptable to a Zoom visit or telemedicine. Next slide. And then there's the TICS. So this is a telephone-based exam. I'm suspecting it's not something you would commonly do, frankly, in a primary care visit, because it is a little more, takes a little longer, though not really that much. There's actually 50 points. I mean, there's a lot of questions. Well, if you count all the separate answers, and it's actually probably tougher than the Mocha. You have more words. There's a 10-word list instead of 5, and so in some sense, it's actually so maybe even a little harder test to do for patients. But it is, you know, it's been validated. It's a commonly used test for just telephone-based interviews. Next slide. Okay, so I think in my sense of it is the whole idea of the cognitive testing, particularly when we do it in such a brief manner, is really just to determine is a person normal or abnormal. And also, by the way, keep in mind, you can score normal on these tests or in a normal range and still be abnormal. But you're not probably going to be able to differentiate the type of dementia or get a really good sense of what specific disorder it is just by the screening test. So I think these screening tests are really, is the person clearly having an abnormal, is it functioning abnormal, not functioning, scoring abnormally, which would match the history that you're getting. The neurological exam, though, I think should be included too, even on the front lines, because it is useful to help differentiate where you go as far as the testing. And you don't have to do the whole neurological examination. I think the primary parts are really the motor parts of the exam, because that gives you, I think it helps identify people that may have a vascular component or an extrapyramidal component that may go with like Lewy body disease or Parkinsonian condition. So, so anyway, I think having at least a brief neurological exam that surveys the motor function is very worthwhile. And I'm going to go through these things. Well, first, there's the observational part. So are you looking, so you're looking for, is the person hypokinetic? Do they have a decreased blink rate? Do they have lack of movements? Because sometimes, if you just look at somebody sitting in a chair, they're kind of moving, kind of moving around a little bit, as opposed to somebody who has an extrapyramidal disorder who just, they're just there. They're just kind of very stiff and not blinking and kind of stare, flat, kind of masked faces, that type of stuff. So that you can just do from observation. And also looking for asymmetries. So in the face is a good place to look because it has so much representation in the brain. So looking for flattening the nasolabial fold, for example. And then if you can see other parts, is there a tremor, is, other things that you can pick up just by observation. And then the motor testing actually, I think, can be done pretty quick. And if I can stop sharing my screen now, I just want to, so I'll demonstrate kind of the things that I do. And so to assess motor function, and again, what you're looking for is really subtle weakness. I think some good tests are the arm roll. So that's just having the person, roll their arms. If there's a side that has subtle weakness, of course, it will fixate. So one will be going around and the other will be not as much. Now you have to be careful, of course, because if they broke their shoulder or, have something else orthopedic on that side, all bets are off. But provided they don't, and they're going like this, it would suggest that they may have something going on the other side of their brain to affect it. The other good place to look, well, aside from, drift to see if somebody's kind of drifting down, is with fine hand and finger movements. Because again, aside from the face, the hand has the largest representation in the homunculus. So it would be more likely to show subtle changes. And the common things you could do is either find finger movements, which may be done well on one side and slow on the other. Hand open and close versus the other. These also can pick up things that might be seen in extrapyramidal features. And then there's also one that you could do with rapid alternating movements, just having them go back and forth. And again, I think these are all simple tests. You can do them in less than 5 minutes. But to get some sense of could there be some subtle motor signs that then suggest a non-Alzheimer's disease condition. The other thing I should say, it's always worth seeing somebody walk, as you know. I mean, a gait can tell you a lot, and that would be the other part in terms of the physical examination. Now I'll go back to the slides, please. And next slide. So once you've gotten to that point, you've done the exam, you pay, I think then that determines what your next steps are. So certainly the common things, if somebody's, if they're impaired and that you've demonstrated cognitive impairment, then actually they probably all should have the dementia battery of lab tests and some type of brain imaging. I mean, that's been the recommendation from the American Association of Neurology. Because even in people who you don't think have any, might have any brain findings, that's structural brain findings, at least 5% of the times you'll find something. It may be a silent stroke, or maybe, so things that you would act upon in doing it. And then I think it becomes a choice of whether, how comfortable you are in handling the case. That is, if you have a gradual progressive course of, delayed memory problems and some executive dysfunction, and they have a family history of Alzheimer's disease, and they're 80 years old and their tests are all normal, they probably have Alzheimer's disease, and it would certainly be appropriate to treat them as such. And but of course, if there's anything atypical, unusual, if you feel uncomfortable handling, then I think a referral to a dementia specialist would be appropriate. So, so I'm going to stop here, and then I guess any questions that you all might have.